is the third in a series of workshops that the HQSC had put on in Christchurch, Wellington and now Auckland, and have allowed the engagement of people from operating rooms around the country in some of the initiatives that are going on in that relate to surgical safety. It's an opportunity, obviously, for some presentations from visiting speakers, but it's also an opportunity to hear what's going on in each of the regions, what the challenges are, and how some of those challenges have been solved. And one of my tasks, I'm Ian Civil, by the way, I'm a vascular and trauma surgeon from Auckland City Hospital. All right, we are now about to start, and it is my great pleasure to introduce Professor Clifford Ko. Now, anyone that does any reading in the area of surgical safety or quality improvement is bound to have come across papers co-authored or authored by Clifford Ko. He is the Director of Research and Optimal Patient Care at the American College of Surgeons, and is a colon and rectal surgeon in Los Angeles, and a prodigious publisher in this area. So we're very, very lucky to have had Clifford here for this week, and it's great to be able to have him here in Auckland, and he's going to speak to you now on surgical teamwork and communication. Thank you.
Thank you, Ian. Good morning, everybody. When Ian asked me to speak to you all in Christchurch and Wellington about this topic, I was very happy to do this, because in my role and in my job in the States, it's really about quality, and how do we give better quality, how do we evaluate, but really how do we improve it once we know we want to get better. And a lot of folks think it's how I throw a stitch or how we give antibiotics and all that, but really the basis of it, the foundation of it, is teamwork and communication. And to a lot of people who don't do quality improvement, quality evaluation, when they hear the importance of teamwork and communication, they poo-poo it. They're like, I know that. What stitch should I throw? What suture should I use? What antibiotic? What dose? And they kind of miss the point. They don't get if somebody says, "Oh, okay, yeah, I know that. We'll just go on to the more important stuff." I know that they do not understand, or they haven't tried it, or they haven't done it well enough, because the key to achieving better quality for our patients, and in a sustained way, not just kind of doing it for a week and then moving on to something else, but to sustain it and to achieve it, it is really the foundation is really communication and teamwork. So I was really happy when he asked me to talk about that. I will have to say that in Christchurch, I gave a presentation and I changed it around a bit for Wellington, and then after Wellington, I was changing it around a bit, except I was trying to watch the cricket match, didn't understand the rules, and so I was just glued to the TV and like, what? Was that a good thing or a bad thing? So this is a new presentation. I have to apologize if I stutter and not knowing where it's going, because I was watching cricket. So, first off, I'm going to talk about the millennial environment. I put this in the talk yesterday, and I think this is true. We live in a millennial environment. We're not. I don't know if there are any millennial generation in here, but we live in a millennial environment, and we have to play by those rules, or play in that sandbox. And so, one of the things that it's about the millennial environment is that we have a shorter attention span. So we have to really get to the point fast, because nowadays people's attention spans are so short that if you don't grab them, we lose them. I live in Los Angeles, where the whole town is based around the entertainment industry, movies, TVs, and everyone is like, we have to make something that's going to grab them within a few seconds, otherwise it's going to be lost. So getting to the point is really, really, really important as we're working on what we're doing. Multitasking. A lot of us are multitasking, and we think we can do it well, but most of the studies show that we don't, even though we think we do. And so, we'll see people driving and eating and texting and, talking on the phone, or we'll be working and doing this project and that project while, I can't tell you how many times I walk into an operating room, and it's usually the plastic surgeons who have a headset on and they're talking on the phone while they're operating and all this stuff going on. We think we can multitask. We can't. We can't do it as well as we think we do. But it doesn't stop us from trying. Out of the box, we draw on lots of material. So we have a lot of information at our fingertips. We can go on, we can turn on our smartphones, we can get any information that we want, we can put stuff together, we can, nowadays when I round on the patients with the medical students and with the residents, I'll ask them some question. What are the 10 reasons why this laboratory result is abnormal? And they'll go through and they'll give it to me. Like they don't know it in their head. They'll find it on the internet. And so we have lots of materials at our fingertips, which is a good thing and a bad thing, because sometimes we get too much information and we have to prioritize. And if we are not used to prioritizing or prioritizing for the group, that can be a not a good thing. We have different languages, different spellings. We shorten things. OMG. I can't tell you how many times I get OMG in an email from people, or more likely WTF when I ask them to do something. So, but we do have a different language. So things are changing really quickly with this millennial environment. The great thing about the millennial environment is that regardless of all this stuff that's going on and having to feel like we have to multitask because of all the balls we have to keep in the air and all the our plates are all full, is that we're all still trying to make a difference. The dedication is still there. Even in the millennial generation, that dedication is there. I can't tell you, all of our trainees, our surgical residents, want to do global health work. They want to go into the third world countries and help them, and they would rather do that than do research, than do a lot of things. They'll take their vacation time to go do that. That dedication is really kind of a foundation of what we're all trying to do, and so there's a lot of hope, and we feel very good about the millennials in that. But the problem is that there's a lack of experience. Because we have so much information at our fingertips, and we can get it so easily. We can go, our students go to Wikipedia in a second, and they download, whether it's right or wrong about Wikipedia, it depends on the topic, but, they'll download all this stuff and cram it into their head for a test, for a rounding, for, when we ask them questions, for oral exams. They get all that information, but they don't have the experience. They don't know what it's like to stay up all night necessarily and take care of a patient and sit at the bedside, or be in the operating room when there's bleeding that you can hear and it's hitting the ceiling and all that, or stuff. They can read it and they know how to give a textbook answer, but they don't have the contextual, the perspective, the observational, the experience of doing that. And so what we're told is that when we nowadays, and we're all kind of living that because we have so much information, one of the best ways to give that as best we can without having them there when the bleeding is terrible is stories, is to tell stories. So putting it into a story gives it context, gives it perspective, makes it kind of real as you can get with these. And so I'm going to try and tell some stories, relay some experiences in quality improvement, in communication, in teamwork, where it's worked. And if we can learn from those situations, or hear those situations, learn from the situation, take something back to where we live, where we work, that'll be a win. A lot of times these sharing of these stories are very instrumental, because we'll be in a situation where we think something's impossible. Oh, that'll never work. We can't get our people to talk to each other, or we can't even get them to meet because the anesthesiologists come in early, the surgeons come in early, the nurses have different break times, the pharmacists come in late, and the hospital administration, they're all busy with me. How do you even get people to meet? When you start to hear stories and examples of how people have solved barriers, have overcome barriers, it's very instructive. So that's what I'd like to do. So I'm going to start off with this one. Once upon a time, there was a surgeon who was in Boston, and I don't know if you've been in the States and what we make fun of in the States or not, but we always make fun of Boston for this reason. There was a surgeon about 100 years ago, and he thought that it would be great if we could collect data. Now, this is 100 years ago, no computers, no smartphones. If we could collect data on how we're doing in our surgeries, and every so often review these things and benchmark against each other, learn from each other, from who's doing well and who's not, and not doing, the people who weren't doing well, their hospital's not doing well, would learn from the ones that were doing well, and then, raise the tide and lift all boats, and we'd be great. And he came up with this system. It's called the end results card. I know you can't read this, but it's basically like our op note or operation dictation, and our, at least in the States, the brief op note, where we write or type what we did, what our findings were, and how we're going to treat this patient and whatnot. And so that's what this card is. And he started doing this, and it was called the end results card. It was the end results program, because he wanted to know the end results. And if this surgeon's rate of complication was 10% and this surgeon's was 2%, let's learn from this surgeon. And he did this. He tried to get all his colleagues to do this, and they basically said, why would we need that? We're good already. We don't need to have data to tell us how good we are. And so basically this idea never got off the ground. He was kind of kicked out of this place, and this was at Harvard. This is one of our best kind of institutions in the States, and they kicked him out. He tried to do this at another hospital. He didn't do very well. He kind of died a poor man, but he really thought that this was the right thing to do, and he's very famous for writing this. The end results idea may not be fulfilled, achieve fulfillment for several generations. This was 100 years ago. This was in about this quote was from, I think, 1917, so almost 100 years ago, that and his name is Ernest Codman, he tried to do this. Now he's heralded as a hero. There's Codman Awards. Mass General, which is the Harvard hospital that kicked him out, has a Codman Center because, now we love him. But this was what this surgeon tried to do 100 years ago. Now, if we fast forward 100 years to now, established in 2004 was this program. It's called the ACS, American College of Surgeons National Surgical Quality Improvement Program, or we call it short NSQIP. And basically, it does what Ernest Codman wanted to do 100 years ago. It collects data. And so one of the first observations that I want to share with you about hospitals that do well with quality and whatnot is that we need data. We need data that are believable. We need data that are accurate, data that are actionable. And that's one of the first things in trying to do anything. And I know we're going to talk about briefings here, but we need data to show that either there's a problem that we need to fix, or a starting point, so that when we get a month now, 6 months from now, a year from now, that are we getting better? Are we getting worse? The question always comes up: how do you know you're good? And the flippant surgeons will say, "Of course I'm good. I don't need anything else. I'm good. You want to know if I'm good? I'm good." And without any data, and that's ridiculous. Nowadays, that's ridiculous. Maybe decades ago, that was okay because we didn't have data and you just had to take them for their word or something. Now we have data, and now it should be data-driven whether we're good or not. So this program tells us how we're good, and it uses outcomes, and there are some ideas here that make it rigorous data collection, that it's clinical data, that it's strict follow-up, that there's importantly, there are strict standardized definitions, because if everyone uses a different definition, we're going to have variability in the results, and we're not going to know if it's variability in the clinical aspect or it's just that the variability of people just recorded things differently. A trained data collector, it's audited, but here's the important part. Outcomes, the data are risk-adjusted, benchmark, and fed back. Risk-adjusted means that you level the playing field, because if one hospital takes care of higher acuity, older patients with a lot of comorbidities, and another hospital doesn't, to compare them, to benchmark them, we need to level the playing field and take that into account. We can do that statistically with a whole bunch of math and a lot of Greek letters, but we need to do the risk adjustment so that we can level the playing field, and then benchmark, which means like we can compare, and feeding it back. Now, feeding it back is very important, and this is how it's fed back in this program. Now, we're not going to talk about this program necessarily here. That's not the reason we're here. But the key point to take home is to feed it back and have data that spur on movement, that spur on action. That is just, we're not happy with our results. And then when people get results back that they're not happy with, they go through those stages of grief. They get angry, they kick the table, then they start crying, then they bargain, all those, whatever those are. But this is the report that we give back. And you can see that the pink line is 1, and that's a wash. So basically, any hospital that crosses the pink line is as expected. These yellow dots, each individual dot is a hospital, and that's their point estimate, and these up and down lines are the confidence interval. So basically, without going into too much detail, these are the hospitals that are doing well. Their rates, and this could be a rate of anything, a rate of mortality, a rate of infection, the rate that they're doing their briefings or timeouts or whatnot. These are the hospitals that are below expected. So they're doing better than expected. Their rates are better than expected. And so these are the low outliers, and again, better than expected. These hospitals are the high outliers. They need improvement. Their rates are too high. Their compliance is terrible, and their rates of incompliance are not good. Their rates of mortality are too high. Their rates of infection, whatever the analysis is, these hospitals need to do better. In this program, in this NISQIP program, when we feed back data, and we don't go to the hospital and help them figure out what's wrong and help them, improve. We at the American College of Surgeons, we collect the data, we analyze the data, we feed it back. Once we feed it back, what we've seen early on in the first several years of the program, that when we do that, 82% improve their complication rate in a statistical way, and 2/3 improve their mortality rate in a statistical way. All we're doing from the American College of Surgeons standpoint is we collect the data, we feed it back to them. It's up to them to move on it. And we see, when we look at them longitudinally, most of them improve. And this was over a 2 or 3 year span. When we did this analysis over 8 years, because the program's 10 years old, and so it's over 8 years, we see that there's improvement. And importantly, that there's differences. What we found from this, the secondary finding, is that different things are easier to fix than other things. Some things are easier to fix than other things. So UTI is easier to fix than pneumonia is easier than SSI. Mortality is the most difficult thing to fix because that slope is the most horizontal. But the improvement is occurring, and it's from that other graph, that other caterpillar graph, the one that looks like a caterpillar, when you feed it back. So the key point here: data are necessary to get better. So I'm going to share some stories with you from this. From our experiences at the American College of Surgeons. The College of Surgeons, these are all the quality programs that we have. So we have a Commission on Cancer program that looks at cancer quality, surgical, non-surgical, chemotherapy, radiation, all of the cancer care, screening, upfront, surveillance in the back, all of these things. And it's 1,500 hospitals, and we visit these hospitals every 3 years to ensure that they meet certain standards, that they're using their data. And so there's that. There's the trauma program, which is in 500 hospitals. These are 500 level 1, 2, 3, or 4 trauma centers in the U.S. These are the hospitals that also have a data registry so that they get the data feedback, which is clearly important. They go, just like the cancer program, they have standards which they need to meet. They have infrastructure standards, they have process standards of protocols that they have to implement. They have to kind of have communication meetings where they're reviewing or previewing how things are going. So that's the trauma program. Bariatric is the same thing, 800 hospitals. There's a breast centers program, and we're starting now one on pediatric surgery, because the variation in pediatric surgery in the States is huge, and so we're trying to now, we were asked to help start a program with data and with standards for that, and then geriatric surgery as well. And this is the NISQIP program that I just told you about. So from these, we have some things. And again, the first observation is this, is that data are necessary. But as we go further into understanding improvement, data are necessary. You can't have improvement without data, but it's not sufficient. So when we think about having high-quality surgical care, perioperative care, the first part is data collection. And there's some things that are important about data collection, namely the analysis has to be correct and has to be risk-adjusted, and we think that clinical data is better than claims or administrative coded ICD data for many things. But that's just the first step. There's other things that need to be done. And the second step is this, is data feedback, quality improvement planning, and implementation. This is probably just as hard, if not harder, than step one. When we see places that don't improve, and one of the first things we ask is like, well, what'd you do with your data? And I'm like, what data? We sent you reports. What do you do with them? oh, they're here in the desk. And then they kind of shuffle through things and like, oh, they're right here. So unless the data are fed back to the facility, to everyone who's involved with the patients who the report's about, it's not going to do anything. And we know a lot of times in the cancer program, we feed back the reports electronically so we know if they open them up or not. The places that don't open up those reports, don't move, don't change. Their score stays as they don't do anything. And so the first piece, even though it sounds so basic, is the feedback of opening up the data, sharing it with the people who should know it. Sounds easy, but doesn't always happen. Quality improvement planning and implementation is also really important. I think a lot of the stories that I'm going to tell will go to that. Clearly, once you do these things, you have to add in certain things, tools and guidelines, teamwork issues, and standards, standardization, which I'll talk about later. And once you do those things, hopefully you get high-quality care. And this thing keeps on cycling. It's a process that we keep on doing. We keep on cycling through this. It's not just one time and you're there. We always have to understand that it keeps on going. We need to keep on revisiting. We need to keep on reviewing. We need to keep on evaluating. Is the improvement still happening? So that's really important. Now, observation 2 is this term called equifinality. There can be more than one solution to a problem, and we often need to discover what that answer is. Just because the hospital, even if we're in the same system, because our sister hospital fixed something one way, doesn't mean that we're going to fix it that exact same way. So let me give you how we discovered this, or how we kind of learned more about this. We did a project, a 2-year project, with the Joint Commission. The Joint Commission is the hospital accreditation body in the States. And they wanted to work on something surgical because they really believe in Six Sigma improvement strategies with their, it's DMAIC. But it's basically you take the data, you analyze it, you feed it back, you scale it, and you learn and you improve. So we said, all right, we have a problem, or the United States, a big problem with colon operations and the infections that happen after colon operations. Well, a colectomy is a great tracer procedure because it's done in all types of hospitals for many types of diseases, and it has a very measurable complication rate. The complication rate is around 25%. So 1 in 4 patients in the NISQIP program with rigorous data collection and standardized definitions is about 25%. 1 in 4 patients have a complication. Of that 25%, 15% of patients have a surgical site infection. So it's a real problem, and surgical site infection is either at the skin, at the fascia level when the fascia dehisces, or when there's an intra-abdominal infection where there's a leak. Basically, you put the two ends together, and it opens up, there's a leak, and it manifests in all kinds of different ways, but that's all that's included in surgical site infection. What the project did was to get 8 hospitals together, and this was a 2-year commitment. This was over $1 million project. And these 8 hospitals, first of all did a lot of colon operations, and second of all, had a higher than expected infection rate. And they said, all right, we want to fix it, and if we could do this together, terrific. So we got 8 hospitals, and these are, you might not recognize these, but in the United States, these are very, very, very good hospitals. The Mayo Clinic is usually one of the top hospitals in any list that you look at. Cleveland Clinic, same thing. Stanford Hospital out, in California, very good. Northwestern Hospital in Chicago. If you ever visit Chicago, you see Northwestern all over the place because they're just taking over, and they really pride themselves in giving good care. All these hospitals got together and committed to a 2-year project and wanted to improve their colon surgical site infection or infection rate. Now, the leader of the Joint Commission is a very smart person, and he said, if there is an it factor, we're going to find it. And he was certain there was going to be an it factor. a factor with which we can, this one factor, we'll find it, and then we can spread it out to all the 5,000 hospitals in the U.S., and they will not have any longer any problems with surgical site infection in colon operations. Now, I'm a colon surgeon. I've been doing it for over a decade, and I've read all the literature. I've studied it. I'm on the practice guidelines committee of our society, and there is no it factor that I know of. But he was very confident in doing that and saying that we'll find an it factor. So if we skip to the end, we see that all the hospitals got better, and basically their rates went down significantly from the intervention to the post-intervention phase. So the hospitals all got better. But if we look at it carefully, and let me explain these to you. These are the 8 hospitals, and we looked at all the variables that were correlated to an infection at each of those hospitals. And the Six Sigma technique collects a lot of data. So we had all these people collecting data and figuring out what correlated with infection. And it's a list of over 200 things, but this is only a couple slides. There's patient characteristics and there's surgical procedures. And you can see that, for each of these hospitals, there is no single thing where there's an X across the board for every hospital. There's no factor that is important for all 8 of these hospitals in terms of a correlation with infection. So whether we looked at characteristics, surgical procedure, antibiotics, people perseverate on antibiotics, but there's nothing there. And preoperative and intraoperative process, there's nothing there. There's no one it factor that every hospital could use to fix its infection rate. And basically the finding and the conclusion of this study was that each hospital had different factors associated with its own infection rate. And so what happened is that each hospital had a different solution for fixing their infection rate. And it was a different rate. So some hospitals, the Mayo Clinic fixed their problem in 3 months. The Cleveland Clinic, which is largely very similar, they're a high volume, they do 2,000 colon operations a year, as does Mayo. They needed 21 months to identify what they were doing. It's not for a lack of trying, but the Mayo Clinic, the first thing they tried, they kind of got lucky right out of the gate, and the first thing they tried, their rates went down and stayed down for the rest of the project. The Cleveland Clinic, it took them, they tried this, and at 21 months, they tried something with antibiotics, it went down, and then they got better. So this was very instructive for us because there was no it factor, and each hospital had to identify the fix and implement it. And as Cleveland had to do, they had to cycle through that thing over and over again. They had to really kind of perseverate and work at it. This picture shows it pretty well, that you have your different hospitals starting here. All hospitals were able to reach their goal of achieving improvement, but the key part of the equifinality piece is that there's different solutions, different paths, and different timings. So for us trying to improve something, and we're all trying to work together in improving X or Y or Z, hearing about other people doing it, terrific, gives us some ideas, it gives us kind of some motivation, gives us some perception, context, but we often have to figure out what's going to work at our own place. Some place might say, oh, that won't work because we have a surgeon who doesn't listen. Or that might not work because we, start our ORs at this time and not that time. Or this, every hospital is individualized in that aspect. You always hear that you see one hospital, because it doesn't always necessarily translate to something else. So there is no it factor. So observation 1, data. Observation 2, equifinality, the idea that we kind of have to discover ourselves what's the fix and implement it. Observation 3 is standardization. We always hear about this. When we have quality, poor quality is when you have a lot of variation. Like one time I'll operate and I'll do it this way. The next time I operate, let's just do it this way. And the third time I operate, let's do it that way. That is not good quality. That is not reliability. We want to be an HRO, a highly reliable organization. We want to know what's happening every single step of the way, how it's happening, and if it's standardized, I'll know how it's happening. The anesthesiologist will know how it's happening. The nurse will know how it's happening. The head of surgery, everyone will know how it's happening because we do it the same way every single time. The more we can get to that, the better. And so we want to standardize evidence-based practice where we use the best research evidence married to clinical expertise, married to what the patient wants. And what we want is that we want to take all these different, people, surgeons, anesthesiologists, whatnot, who do it in different ways and have them all do it the same way. Once we do that, we're going to be a lot closer to where we want to get to. When we did this at where I work, we got the colon surgeons together. There's 6 of us, and we standardized. It took us almost 2 years to do this, meeting a lot. We were yelling at points. We were just like I'm leaving and acting like babies at points. But we standardized. We standardized our instrument trays so that my instrument tray was this big and somebody else's was this big, and it used different instruments and all this stuff that looked like it was from the the 1500s and like what is that instrument? And so that we standardized how we take care of the patients beforehand, what tests we do, what tests we don't do, reasons why we do this, and post-op. When did we feed them? When did we ambulate them? What were our criteria for discharge? When do we follow up? Follow-up was a huge thing. Some people would call their patients on the day after discharge. How you doing, Mrs. Smith? Blah, blah, blah. Other doctors, other surgeons who were there, same age, it's not like a generation thing, said, oh, if they have a problem, they'll call me. Or if they have a problem, they'll come back to our clinic. And then what we changed also was that we put the right phone number on our form, our discharge form, because it was the wrong phone number. So some things are really important, and that really helped because our readmission rate within 1 quarter, within 3 or 4 months, went down from really high to, this is average in the U.S. for readmission after a colon operation. So that happened within 3 months. Although it took us almost 2 years to standardize. If any of you are working on standardization, a great project to do it in is ERAS, Enhanced Recovery After Surgery. And this is a program that involves surgeons and anesthesiologists and nursing and pharmacy, because the processes that everyone standardized are evidence-based and in multiple disciplines. Pain management by anesthesia, fluid management by anesthesia, the ambulation issues with surgery, the pre-op education that we do in the clinic beforehand. Most of the education is best given by the nurses rather than the surgeons. But having all that, having the whole team play into that on evidence-based and standardizing it has shown over and over again that there are great gains. This is just one graph, the systematic review of the reduction in length of stay of these things. I can tell you that the length of stay in the NISQIP program, where we collect that for a colon operation, is 7 days. With laparoscopic, it's 6 days. For hospitals that are mature in the ERAS program, their length of stay is 4 days, and laparoscopic is 3 days. So it basically cuts it almost in half with a protocolized, standardized, evidence-based way of doing things. And I think that when I see hospitals now, when they want to try to work on something, I always say this because it's already out there. We already know what to do, and the hard part is getting people to do it. So hospitals like, our anesthesiologists don't want to give an epidural, or that's too little fluid, or we don't feel comfortable feeding our patients. So as soon as people get over those things, the protocols are already there, and it's a great way to get things going in your hospital, regardless of whether you're a mature quality improvement place or you're just starting out. So the whole reason people are here is really to talk about briefings, and I'm going to talk a little bit about it. For the rest of the day, we'll talk a lot more. But implementing briefings, we've done this in the States, I think, for the last 5 or 6 years. At our hospital, we've done it for 5 years. And I can tell you, as a surgeon who hates doing things that are a waste of time and a waste of energy, and sometimes is just bullheaded in the operating room, briefings are amazingly great. They are a standard way to communicate, basically. They're a standard way to share information that might not be shared otherwise. And it's a great way of improving just kind of the morale and the spirit of teamwork. And so this is just some results that we've had just at our hospital that I haven't shared with anyone else, but I just found these on my computer while watching cricket. But basically what does a briefing do? It maps out the plan of care. So, I know in my head what I want to do. Usually, I hope so. And anesthesia probably does, and nursing probably does. Do we share with each other? Usually not, until we did these briefings. It identifies the roles and responsibilities of each team member, so I know what I'm doing, and the nurse knows what he or she is doing, and the anesthesiologist knows what he or she is doing, scrub, circulating, and whatnot. heightens awareness of the situation. This is a really sick patient, has a bad heart. Anesthesia is saying, all right, if we lose too much blood, we have to transfuse maybe at this instead of this level. And I'll say, all right, well, if the area we're going to lose blood is this part of the operation. Ask nursing, like, if I lose blood, I need this stitch, and I need a sponge stick, and I need help. Where's the vascular surgeon? So those things allows the team to think about the unexpected. Team members' needs and expectations are met, which is a huge thing, because if we start an operation and my needs or expectations are not addressed, or the nurses aren't, or the anesthesia, that is not an optimal way. Certainly we would not get on an airplane where that is happening and the pilot doesn't feel comfortable and the expectations or our needs are not met. And it's really, again, down to perceptions and context. These things are communicated. So we're now, when people don't know what they don't know, we're now allowing them to know what they should be knowing. And so that's really important in terms of the whole piece. But I think that I'm preaching to the choir here that you all know this. Here's just some data from our place. There was an unexpected OR delay. Like, Cliff, your instruments are being cleaned. You didn't tell us you needed that. Like, well, I thought, like, you knew. Can't you read my mind? So until we start communicating these things, there's these delays. And so that decreased from 30 to 20%. So that's a 30% improvement, which is good, because there's always still going to be delays, but that decreased it. It was difficult to speak up if I perceived a problem with patient care. So this was hopefully less common, but this was at 30% there, and now it's at 5% at our place. So that went down. People feel empowered to speak up. On an airplane, they always say that the flight attendant, if they see something wrong, they get in trouble if they don't tell the captain. The other day I was on an air, now it was about a year ago. Somebody fainted in the back of the plane. They asked us to the doctor, and I mistakenly told somebody that I was a doctor, and then I had to get called back there. And and this person was, I think, drank too much the night before and was vomiting. It's just dehydrated. So it's just dehydrated. And so I was just going to put in an IV, and the flight says, like, don't do anything. I have to tell the captain. So anything that goes on, the communication of that, and if there's something wrong, they have to feel empowered to speak up, and so that happens. If there's a problem with patient care, you want to hear from somebody that, Cliff, there's blood on the floor, or there's something spurting, or is that stool coming out of your connection? So I want to hear that. I don't like it, but I want to hear it. I knew the first names and last names of the people in the OR. There's a lot now of changing in the operating room. We have multiple teams. We have a lot of visitors. We have people coming in and out. Knowing their names it just helps everything. And there's some briefings where just they're very familiarizing, and so they'll say, call me by my first names, which sometimes works, sometimes doesn't. Like at the American College of Surgeons, I have everyone call me by my first name, but my boss doesn't. So but people call him by his name, and they don't just say, hey, you, or anything like that. They're just pretend like they don't know, they know the name, but they're just choosing not to say it. Knowing people's names really matters, and when you use their name in a conversation, it matters, and so it helps get that collegiality in place. And so the briefings starts off as an introduction, and sometimes like you meet 7 new people, like I can't remember that, and so you write it down on the board or it's up there. So at least you start off in how we would start off at a cocktail party when we meet somebody, and how we would just be social, and how we would just be working with the team. That's really important. So, and that's the fourth observation from what we're trying to do is communication and teamwork culture is routinely associated with achieving sustained quality and safety improvement. So I'm going to go through this. There is a set definition by the sociologists of what culture is, but I'm not going to read that because I'm a surgeon and I can't understand it. So it's usually this one. The way things get done around here, that's our culture. Is it done with communication? Is it done standardized? Is it done haphazardly? Is it done sloppily? Is it done open and reliably? That's the culture. Do we communicate how we're doing? Do we identify our problems and communicate that out? Do we message our fixes or not? So the way things get down around here. Culture. It is the most difficult thing to fix, to change, to move, to advance, to progress. It is something that we have to constantly perseverate on. Because if we don't, it easily falls back. And people, there are ways that, like a single person or a single group can kind of torture your culture and not make it work. It is something that we have to roll that boulder uphill every single day, and then it'll get easier and easier. And once you have a good culture, and once it's moving forward, celebrate it and keep on moving. It'll get better. But it is something that people say takes years to fix, but it is fixable. And when you work in a good culture place, it's amazingly great. And when you see a good culture place, you want to be cared for there. You want to take your family, if they need an operation, to that place. So I'm going to tell you this story. This is the caterpillar graph. It's for colectomy, and again, these are the good hospitals. These are the bad hospitals. And this is a complication part. And this is really a story about perseverance and achievement. This hospital is terrible. They are the second to worst hospital in the program for complications in colectomy. So I told you the complication rate is around 25%, and the infection rate is around 15%. They were the second worst hospital in terms of the feeding back benchmark data. So they came to the college. They called us and said, "Are you sure this report is right? I think it's upside down. We're actually the second best hospital." No, and they said, "Well, I guess we have a lot of infections." And when we looked at the data, they shared us their data, and they looked back at the cases that we said were infections, and they were in fact infections. This hospital had the highest colon surgery infection rate, amongst the highest at 27%. So I told you that it's about 15%, and so they almost had a double the rate of infections. And before I get to this, it was a good hospital. It's usually one of the top hospitals in the lists in the states of hospitals to go to. It has a rich history. It is very famous. And they do about 500 colon operations a year. They have many surgeons doing it, and they're one of the best hospitals by reputation. First thing they did was they got a team together. And you'll notice from this slide that most people are smiling. But other than that, it's multidisciplinary. So they had people from anesthesia, and they had people from surgery, and they had people from the operating room. They had the nurses who lead there. They had a data manager. They had a coach from the hospital who was the quality person. And then they had, in fact, a senior-level administrative person, the head of quality, who's kind of one of the C-suite people of the hospital. This was their team, because this was a problem, and they don't want to be one of the worst hospitals in the country, and something that's very common to do. So they put this team together, and they had regular meetings of the team. They started off, and we at the American College of Surgeons decided to work with them and kind of do a case study and follow them from their beginning to whenever their end was. And so they had regular meetings of that team, so all the kind of leads in different areas, but they invited the staff. In the beginning, they held the meetings every month, but then they needed to do more work, so they held them every 2 weeks. They found a time when everyone could meet. It was actually important to have the administrator there, because the administrator said, whatever you're doing at this time of the meeting, I will make sure you get your time off to work on this. Because a lot of times, if we don't have that, then we're working on Saturdays at 7 in the morning, and nobody wants to do that. So there was time off from the administrator. That was really important for have that support there. But they had these regular meetings, and they had those team leaders there, but they also invited the staff. In the beginning, not many of the staff would go. Towards the end of the meeting, because they were doing so much of the staff was there, and it was standing room only in these conference rooms. And so that was the attendance grew. What they did was they empowered frontline providers to brainstorm and identify what to work on. So they wanted to get not the administrator saying, "Oh, this is what the answer is. You do what I say." They employed the frontline people who do it day in, day out to figure out how to work. Why do you think that these patients are getting infections? What is it in your area where you are the expert? What do you think we could do differently? So they got the team together and asked that. And they identified improvement steps. And this is not a bundle that you should all try if you have an infection rate in your colon patients. But this is what they did at their hospital, the Equifinality piece at their hospital. And so they standardized the skin prep. They did better antibiotic dosing. They used gentamicin, and their dosing was not appropriate. They decided to use an instrument tray and changing gloves before closing, so that when they got to that part of the operation, they took away all the dirty instruments off the table and then opened up a new pack just to do the closure of the fascia and the skin. They got the surgeons and everyone around the table to change their gown and change their gloves, so they're now starting off with as clean as possible. And then normothermia. In the States, we get credit. It's a performance measure if we do something to address normothermia, but we never measure the temperature of the patient to make sure they're normothermic. And so a lot of times when people have studied this, it's like, yeah, they turned on the warmer, or they warmed up the fluids a little bit, but the patient was still cold, so it doesn't even matter what they did. This they decided that, because anesthesia said, all right, well, let's try to really actually make the patient warm. And so that was their endpoint, rather than just turning the switch on the bear hugger or on the warmer. This is what they worked on. Cut to the chase, their SSI went from 27 to 17%, which is still a little above average, but they went down 37% in 6 months. And importantly, they sustained their improvement to 1 year. And what's really interesting is that their readmissions also decreased, because in surgery, one of the biggest reasons for readmissions is surgical complications. And the number one surgical complication across all fields is infection. So if a place decreases their infection rate by almost 40%, likely their other things are going to get better, like their readmissions, and that's what happened with this. The important thing to take from this is not the clinical piece, and it's not, the teamwork is important, but these quotes really drive it home. Team-based, when we ask the people on the team and we ask the staff, the frontline people who are just there every single day doing keeping their head down and doing their job, team-based approach with each having a key role was really important. It wasn't a top-down thing. It wasn't that, my boss said to do this. They allowed me to think about what I could do better, and put those out as possibilities. The empowering the frontline people to provide and test the solution. So this is that same thing. The frontline people felt like they were being listened to. And so that's this thing. The biggest difference versus the past was that everyone participated in the process, felt that they were valued, believed that they were helping the patient. There was dedication, teamwork and collaboration, and importantly, there was engagement. And that's culture, right? How often does that happen in a hospital with poor culture? Very rarely, if ever. How often does a team get together and communicate and try to ask for people's opinions? Very rarely. How often, they always say a great leader or a great person who's part of a team will listen 80% of the time and talk only 20% of the time? And how often do we have those things reversed by some team members? So that's what really good culture is. And if you look at this graph, we tried to do some science on this. That when this unit first started, they measured their communication and teamwork with a survey that we use in the States called the SAQ, the Safety Attitudes Questionnaire. And it was one of the worst units in the hospital. The collection of people from pre, intra, and post-op rated it were one of the worst units in the hospital. They didn't trust the hospital. They didn't trust their colleagues. If they had a sick family member, they would not bring them to that hospital. And that's where they started. 6 months into it, their scores got better. They started to see some achievement, and they started to work together better. They started, they met regularly, but they actually enjoyed and looked forward to meeting regularly. It was infectious, and more people came in to do that. And then by 2 years out, this is a measurement at 2 years, they were one of the best in the hospital. And it was infectious in that other kind of areas saw what the colon team was doing and got jealous. Like, what are they doing? Why are they so happy? How come they get, accolades and they get acknowledged all the time? And in fact, the urologists who were kind of shared the floor, because colon and urology are kind of similar patients. They stole that coach. They got that coach to work with them because they wanted to have what the colon team had in doing that. So what the lesson we learned there is that even though we think about culture, what is the universe that we're talking about? Is it the whole hospital? from this, we see that even within a hospital, there's different pockets. There's different silos within a hospital. And we don't like to use the word silo. But there's different pockets in a hospital, and the culture being totally different. And we could be working right next to each other. The urologists operate in the room right next door to where the colon surgeons are operating. They share the same floor, yet their cultures were very different. And so culture is mutable. It's changeable. It can improve. And putting the right team together, putting the right communication together, and it can improve the care, and it can improve, and the culture also improves. And I'm gonna end with these slides because I think it's time. But knowing your level of engagement, and there's a lot of words for culture: communication, teamwork, engagement, climate, whatever you want to use. But if you want to, knowing where you're starting from, again, this is the data and the feedback, and knowing where you are and how good or not good you are. What's your level of engagement? And clearly there are, people who are actively disengaged. They try not to engage. They do things and not to engage. And then there's the actively engaged who are actively doing that. And there's things in the middle. But this is, and these are the people who create a mess. These are, if you read Jack Welch and Good to Great and Built to Last, those type of books, I don't know, but they look at companies and how do you make your company great, and how do you make your company great now, and then when the leader leaves, how can the company still be great? And basically, the one thing that they say is you get the right people on the bus, you get the wrong people off the bus, and then you have to put the people in the right seat. And so this is what this is here, is that, these are the people who create the mess. Get them off the bus. Just these people should not be on the team, should not be there. These are the disengaged. They walk past a problem without thinking about it, without worrying about it. These opportunistic people, these are the people who are kind of standing by the side until something comes up, and they hope not to see it, but if it's their own, they'll clean it up. So I have a problem with my patient in the wrong site, sure, I'll fix myself. But if there's a problem anywhere else, I don't see it. Engage, clean up what he or she sees, so that I see something is happening, I'll participate in, as it happens. And then the actively engage are these people, they'll help clean up, they'll help fix it, they'll help prevent it, they'll help champion the briefings when they come into the hospital. And knowing what you have in your place, in your operating theaters, in your hospital, in your systems is really important, because, who can you count on to be the champions moving it forward? Who are the people who are going to be kind of like, twiddling their thumbs, looking up at the sky, and who are the people who are going to be fighting you every step of the way, and figuring out who your friends are and who they're not. So what would the impact if everyone were this actively engaged? It are these things. But you can see the top 3 or 4 things are the key things that we're all thinking about. Quality. We want to make sure that every single patient that we touch, take care of, work with, has high quality. We want to make sure that it's safe, that there's no errors, that there's not even near misses, that there are as safe and reliable as possible. Clearly, we want to have employee satisfaction, that, as if there are people in the room that have to deal with hiring and rehiring and turnover things, that's usually not a good thing. Certainly there's going to be some rates, but if people are leaving, there's a reason for that. And innovation, I didn't get to that part of the talk, but when we standardize, we need to also constantly innovate. One of the bad things, one of the attacks of standardization is that people say, well, if we standardize everything, there's no chance to innovate, to think of better ways. And really what we have to do is we have to put those two things together. We have to standardize, and then when the data tell us something that, all right, we're not doing something exactly correct, we have to innovate. We have to change management. We have to think of something new. And when we think of something new that works, then we have to standardize. And that whole cycle keeps on going over and over again. And that's what engagement or good culture and communication and teamwork get you. So I'm going to end here. I think my time's up. But I'm happy to answer any questions if there's any time. Otherwise, we can do it later in the morning. So thank you very much.